Hello everyone, thank you for joining our session today about inflammatory skin conditions. This is the third session as part of the Mind the Bleep Dermatology series. Before I start, can you hear me? Can I just check?
Yeah, we can hear you.
Great, perfect. So before we get into it, I'd just like to thank Dr. Aldawani. He's one of the dermatology registrars who's kindly reviewed this presentation. So in this presentation, we'll be practicing what we've previously been through about describing skin lesions, and there are a few examples throughout the presentation. We'll be going through acne, psoriasis, rosacea, eczema, dermatitis, and folliculitis. And at the end, we have a few SBA questions similar to the MLA exam. So to start things off, can you put into the chat box descriptions about this rash and what the likely diagnosis is? Okay, so I can't see anything in the chat yet. So we can use the DCM framework to describe this rash. We can see that it's distributed on the arm, and we can also see, if you look closely, there is also part of the lesion on the torso as well. We would describe this as a patch, and we can see that there is some scale overlying this. So the likely diagnosis for this image is psoriasis. So psoriasis is a inflammatory papulosquamous disorder. So you will see well demarcated scaly plaques, and there will be a relapsing and remitting course. It is more common in Caucasians, and when it occurs in Fitzpatrick skin types 5 and 6, as the previous image showed, it would appear more purple or dark grey in appearance. It's related to abnormal T cell activity. There are two peaks where incidence of psoriasis is high. So one is between 20 and 30 years old, and the other is between 50 and 60 years old. So there's a variety of causes, including infection, drugs, stress, alcohol, a genetic component, HIV, and lifestyle changes. So So the previous image was chronic plaque psoriasis. This is the most common, and they're about 90% of the cases. Others are guttate psoriasis. So this was shown in the previous image here, where you will see drop-like eruptions, and it's often after a streptococcal infection. Then there's flexural psoriasis, which you can see in this image here, which affects areas such as the axilla, the submammary area, and they're smooth and red in appearance. So you may often see this under the breast, especially in GP. I've seen this a few times. Then there's also pustular generalized psoriasis. So here you would see small sheets of yellow pustules on a red background. So this is this middle image here. And sometimes it can progress to erythroderma, which is erythema of majority of the skin surface. Then there's also pustular palmoplantar psoriasis. So this is this image here. This occurs, as the name says, more on the palms and the soles, and it is associated with smoking. And there is also erythrodermic psoriasis, and this is what you can see here. And as with cases of erythroderma, it would require inpatient management, including fluids and temperature regulation. Often these patients would be managed in ICU. So this is the next question. Psoriasis can be worsened due to, so you can put A to D into the chat box. So we'll give you 10 more seconds. Feel free to have a go. Okay, so the correct answer for this question is D, beta blockers. So there are a few medications that can trigger psoriasis. So this includes beta blockers, calcium channel blockers, lithium, anti-malarial medications, NSAIDs, terbinafine, TNF inhibitors, and withdrawal of steroids. There's not many relieving factors. Emollients can be helpful, and often in pregnancy, people may find that it improves, but this can, of course, go the other way as well. So in terms of secondary features, so 50% of patients experience nail changes. So it's really important when we examine these patients to have a look at the nails. So you may see some pitting, which you can see there's quite a few on these nails where there's areas of pitting, ankylosis, subungual hyperkeratosis, which you can see at the end, and hyperkeratosis. 5 to 8% have associated arthropathy. So this is related to psoriatic arthritis. And there is also the Auspich sign. So this is where scratching of the patch can lead to capillary bleeding. And the scale will be removed due to this as well. So a common scoring that we use for psoriasis is the PASI score. So what this does is it separates the body into the head, arm, trunk, and legs, and rates the severity in terms of how much area is covered, how much erythema there is, the thickness of the scale present, and the amount of scaling present. And this all relates to a score called the PASI score, which indicates the severity of the psoriasis and also helps determine what treatment we would give. So in terms of treatment of psoriasis, in terms of plaque psoriasis, topical steroid vitamin D analogues like Enstellar is a common brand name that is used, is given, and then it would be reviewed in 8 to 12 weeks to assess if there's improvement. Other preparations that you can give is coal tar, which is also available over the counter. Phototherapy is also used for psoriasis, especially PUVA. And there are also systemic therapies. So depending on the severity of the psoriasis, this can be used. So methotrexate, cyclosporin, acretitin, and with this, it's important to monitor bloods, including LFTs, and also biologics. And some places will also have psoriasis biologics clinics where the psoriasis has not improved with the above treatment. And ones that are used are such as infliximab, adalimumab, and also some other interleukins such as I believe 13 is also used for treatment of psoriasis. And then for guttate psoriasis, as this is related to the streptococcal infection, typically they can self-resolve in 2 to 3 months, but a third of patients will go on to develop plaque psoriasis. For this, we can again use topical steroids, coal tar, UVB phototherapy, and if they are having recurrent infections related to tonsillitis, then tonsillectomy may be required. So we mentioned that cyclosporin is one of the medications that we can give for psoriasis. So the next question is, which of the following is not a side effect of cyclosporin? Again, you can put A to E in the options. Okay, I can't see any responses so far. So I think a common one that is tested in exams is hypertrophy of gum. So we know that is a side effect. So the correct answer for this question is hypovolemia, as their hypertension, hypertrichosis, hypertrophy of gum, and rise of serum creatinine are all side effects of cyclosporin. So, this is a common mnemonic which we're usually taught regarding the potency of topical steroids. So I just included it here as an overview. So hydrocortisone would be the weakest steroid, and then Umavate, Betnavate, and Dermavate. So this is quite useful to remember. And depending on the area, the age of the patient, and the severity of the disease, it would help you guide what area you need to treat with. So this is the second image that if you can put in some words that to describe this image and what you think the likely diagnosis. Okay, so for this image, the correct diagnosis is acne. So we can see that there is a papular rash that is present on the cheeks. It may be bilateral, but we can't see the other side. We can see that there are some closed comedones, open comedones, papules, and pustules present, and there are quite a few of these present. So, acne vulgaris. So, this is a inflammatory disease of the pilosebaceous unit. It is common in teenagers, can be related to hormonal PCOS, steroid use, endocrine disorders, and Cushing's disease. So it's related to increased sebum production and abnormal follicular keratinization. And sometimes there can be bacterial colonization associated with it and inflammation. So as I pointed out before, there are a few different types of lesions that we can see in acne. So we would see closed comedones. So these are small papules, open comedones, which you might see a bit of impacted keratin, which gives it pigmentation in the center, and they may be flat or raised. And then we have the inflammatory lesions. So this can include papules. These can include pustules and nodules, which are painful and swelling, and they can be quite large as well. So in terms of acne, there are some scarring that can be related to it. So we can have hyper or hypopigmentation. You can have erythematous macules and also scarring such as ice pick scars, macular atrophic scars, and fibrotic scars. And you can also have things like keloid scars, which can occur on the back, chest, and shoulders, less common on the face, and hypertrophic scars. There are two other types of acne. So conglobate is severe and nodular, and it affects the trunk, face, and it is very tender. And then you also get acne fulminans, which is a severe inflammatory reaction of pre-existing acne. And you'll also have systemic symptoms. So in this image, you can see acne conglobate, where you can see several nodules and it's affecting the back. And for this, we would give systemic corticosteroids, isotretinoin, and would require inpatient admission as it is very painful. Okay, so in terms of management of acne, we would be directed based on whether it's mild, moderate, or severe. So generally, our first step is to use topical treatment. So this would be things like benzoyl peroxide, topical antibiotics such as erythromycin, and topical retinoids such as adapalene. And these are commonly manufactured in a dual combination, such as Epiduo, which has two of these present. If this does not work, and we usually review it after 8 to 12 weeks, then we would look into step 2, which is systemic antibiotics. So oral limacycline is usually first line for this, and we may start here if it is severe acne. If this also on review has not improved the symptoms, then we can discuss isotretinoin, which would require dermatology input. So this is a retinoid, which is a vitamin A derivative, which reduces sebum. Like I said, it's used in severe or treatment-resistant subtypes, and also it helps with improving visible scarring. And we can also refer if there is significant psychological distress. It's important when we are starting this medication to counsel the patient, as it is teratogenic and the patient needs to be on contraception. And also, sometimes it can affect mood disorders such as depression, anxiety, and it can also cause dryness of the skin and the lips, and rarely can lead to Stevens-Johnson syndrome as well. There's also hormonal treatment that we can give. So this will depend on the patient, whether it's cyclical flares associated with the menstrual cycles. They might prefer to use the combined oral contraceptive pill, and also spironolactone can be used for management of acne. So here are some examples of the scars that are present post-acne. So here are some rolling scars. So you can see that they are around 4 to 5 millimeters. Boxcar, which are larger and have a crater-like depression. Ice pick scars, which, like the name suggests, is a bit more like picks, very narrow, and they have steep edges. And we also have, this is an example of a keloid scar, which goes where the previous lesion was, and it is a fibrous tissue growth. So for this, things such as microdermabrasion, laser resurfacing, microneedling, and laser can be used. And for keloid scars, intralesional steroids can be used. So next is rosacea. So this is an inflammatory condition which affects the face, nose, and the cheeks. So you'll quite often see rhinophyma, which is, as you can see in this image, the nose looks very inflamed, and you can see that it has enlarged. So you would see erythema, telangiectasia, and also inflammatory papules and pustules. It is more common in women aged between 30 to 50. And with regards to the pathophysiology, there is some inclination that it's related to the innate immune response or neurovascular dysregulation. So, rosacea can often be triggered by lifestyle triggers. So, this includes caffeine and stress. So, it's important that we advise the patient to monitor if that's making an effect, such as the caffeine, and also advise them to have sun protection. For this, we can give a topical metronidazole cream or azelaic acid to help control the inflammation and the erythema present. There's also bromidine gel, that's an alpha 2 agonist that can be used for the erythema. And again, if this doesn't work, another suggestion could be to use an oral tetracycline or lamicycline for 6 to 12 weeks. So here you can see that there are 4 stages. The first, you can see that there is flushing, and you can see some telangiectasia present, and there might be some burning or stinging of the skin. The second, which is similar to the previous image, it's persistent. So there'll also be some papules and pustules present. And unlike acne, there are no blackheads, whiteheads, or nodules. And again, telangiectasia will be present. Then you will have the rhinophyma subtype 3, where there's thickening of the skin and there's an irregular contour around the nose. And then subtype 4 is where there is ocular involvement, including burning, drying, stinging of the eyes, sensitivity to light, and a foreign body sensation. It can also be associated with blepharitis or conjunctivitis. Okay, so the answer is already there. Which of these is an exacerbating factor for rosacea? So sun exposure can be a trigger for rosacea. Other things include vasoconstrictor drugs, steroids, stress like we discussed previously, sometimes exercise, spicy foods, alcohol, caffeine, as we discussed previously, and perhaps a genetic predisposition. So next we're moving on to atopic dermatitis. So this is a chronic inflammatory skin condition which is quite common. It will have episodes of flares and remissions, and these are itchy, dry, and scaly lesions. And in darker skin types, so Fitzpatrick type 5 and 6, they can appear grey and brown in colour rather than red and erythematous, as the picture below shows. So in an exacerbation, there may be oozing, weeping, vesicles, and you may also see excoriation marks from repeated itching and lichenification, again from repeated chronic itching. So there's about a 20% prevalence in under 12-year-olds, and it's due to a dysfunction in the skin barrier. So it's due to a loss of the function of the protein filaggrin in half of the cases, and that's involved in the conversion of keratinocytes to form part of the stratum corneum. So if you go back to the first lecture, we can see that that is part of the superficial layer of the skin. And then exacerbating factors for a flare can include infections, allergens, sweating, heat, and stress. And sometimes there can be occupational links that can cause exacerbations as well. So the distribution can vary depending on the age group. So in infants, you may see it around the face or the scalp. In children, you'll see it in the flexural areas, so such as the elbows. And in adults, you may see hand involvement. So, there are multiple triggers for atopic dermatitis. So, of course, atopy is one of the things that's genetically related, environment and immunological causes. So, in winter, people often find that the skin is drier. Soaps and detergents can cause irritations, which is related to irritant contact dermatitis as well. Also, overheating or rough clothes, stress, skin infections, animal dander, and house dust mites. So in terms of management of atopic dermatitis, emollient is the main thing, and even during remission, patients need to use emollients regularly. So we can prescribe things such as zero base for this, and we want to ensure that the patient is using this multiple times a day. We can also give topical steroids during a flare-up. So we would need to use the appropriate potency and dose necessary to control the symptoms. It's important that we give it for around 2-week time and then taper it off. Also, things such as tacrolimus, which is a topical calcineurin inhibitor, is used for management of eczema. And also, if there is persistent itching or urticaria, you can consider a trial of antihistamines. Um, Oral steroids may be necessary if it is severe and there is no resolution of the symptoms. And we want to ensure that we're not having secondary infections. So you can see here there's a case of eczema hepaticum where the child would have a background eczema. However, due to infection, there is some painful clustered blisters, punched out erosions, and it commonly affects around the face, can also extend around the nose, the eyes, and they are in clustered locations. And if this occurs, especially in pediatric patients, they need immediate hospital admission and need to be started on IV acyclovir even before if we are suspecting eczema hepaticum before being reviewed by dermatologists, pediatricians would start this. And also here there is use of biologics such as dupilumab. So again, with dermatitis, there's various types. I've listed quite a few here. So we have atopic dermatitis, which we've covered. We have discoid eczema, which we can see here, where there's discrete coin-shaped dermatitis, which is well defined here. You have venous stasis eczema, which we can see here. This is often seen where patients may have venous disease or there's impaired blood flow to the gaiter area. So in these cases, we'd want to check their ABPI to exclude arterial disease and encourage ankle exercises, elevation, and also, of course, apply emollient. We can get seborrheic dermatitis, which we'll cover more in the upcoming slides. And then we have pompholyx eczema, which is this image here. You can see that this appears more vesicular and is more on the palms and the soles and can evolve into bullae, which are larger blisters. This can be exacerbated by stress and sweat, and often this can peel as a rash, and it usually will settle in 3 to 4 weeks. And then we have prurigo nodularis, which is this image here, where there are intensely itchy nodules and also may have a history of atopy, and it occurs on the extensor aspect of the limbs or the upper back and in difficult to reach areas such as the back. So in this case, you want to exclude things like scabies or other systemic causes of itching, such as any renal conditions, liver conditions, malignancy, HIV, or psychiatric conditions relating to this intense itch. And then we also have contact dermatitis, which we'll go into more in the later slides, and occupational dermatitis. So, contact dermatitis. This is inflammation due to direct contact with a causative agent. So, this can include things such as chemical burns, allergic reactions, and occupational related exposure, such as cleaning products, hairdresser equipment. So this will appear erythematous, there may be vesicles or bullae present, there may be oedema, dryness, scaling, or fissures. So we separate contact dermatitis into irritant and allergic. So irritant contact dermatitis is related to the actual chemical or physical irritation of the skin. So this would affect people in contact with this, such as acids, detergents, and soaps. Allergic contact dermatitis is a type 4 hypersensitivity reaction, and this would include things such as metals, fragrance, and for this we want to avoid causative substances. So we would diagnose this based off their history, any exposure that they've had, or any occupational hazards that they've come across. And if we believe it's allergic, we would do patch testing. And in terms of treatment, we would give them soap substitute. If it is related to detergents and things, we would ask them to change it, try gloves and dry skin after washing to remove the irritation, and sometimes topical corticosteroids may also be needed, and of course emollients will be used. So in terms of patch testing, what is usually done is the 40 most common allergens are put onto the back of someone's skin. So this is commonly done where there is no acute dermatitis present, and then this is reviewed in the next couple of days to see which of the allergens have resulted in a wider erythematous area, indicating that there is an allergic contact dermatitis reaction due to that causative ingredient. So this is our next image to describe. And what do you think is the likely diagnosis? We have briefly touched on it previously, which is a clue. Again, you can put it into the chat box if you know. Okay, so here we can see that there is some erythema, some flaking around the eyebrow region of this patient. So this is an image of seborrheic dermatitis. So this is a chronic inflammation, and it occurs commonly in areas that are rich in sebaceous glands. So commonly you'd see it on the face and the scalp, and often on the trunk as well. Um, Dandruff is different as you wouldn't see the inflammation, the redness associated with it, and it would be milder. And it would present as scaly patches without underlying erythema. And there may not be any itching associated with it. Whereas seborrheic dermatitis, you might find that the patients are saying it is quite itchy. In infants, this can look like cradle cap, which you can see in the image here. So this is greasy scaling on the top of the scalp. So the causative fungus for seborrheic dermatitis is Malatia furfur, which is actually quite a common question that they ask in SBAs. So like we mentioned, it would be erythematous patch, such as seen in the previous image, with a greasy yellow scale. Winter, you might see flares. There may be minimal itching associated with this, and it can occur in combination skin as well. There may also be blepharitis associated with it if it's near the eyes. And in darker skin types, you may see some scaly hypopigmented macules and patches. So, in terms of risk factors, there are neurological and psychiatric risk factors such as Parkinson's disease, Down syndrome, and also immunosuppression. Complications can occur such as infection, such as impetigo or otitis externa affecting the outer ear. This can also cause psychological impact as it is affecting the face, and patients may often not understand why this is not resolving despite using emollients. And a rare complication is erythroderma. In terms of treatment, the main treatment is ketoconazole shampoo, especially if it's affecting the scalp. We can also use salicylic acid, selenium sulfide shampoo, or mild topical corticosteroids with an antifungal combination. In infants, emollients is used to loosen the scalp, the scale on the scalp, and topical imidazole cream can also be used. And we would bath them a soap substitute such as Dermol 500. And then we have folliculitis. So this is a condition where there is inflammation of the hair follicle. So it can be superficial, like this image here, or it can be more severe and deep. So in superficial, they can be mild, self-limiting, and appear as papules or pustules on an erythematous base. You may see this might be associated with things like shaving in men, for example, around their beard. And then deep is more associated with infection, and there may also be associated pain and scarring with this. So as you can see here is more erythema, and we can describe this as a furuncle and carbuncle. So causes for this can be infection, occlusion, irritation such as shaving, and immunosuppression or certain drugs such as steroids and androgen. So this again commonly affects areas where there's shaving done, so beards, scalp, but can also affect areas such as the buttocks and the lower leg. Sometimes ointments and moisturizers may cause folliculitis, so we would advise them to swap to an oil-free product. And boils are also a form of folliculitis, usually affecting the inner thigh and buttock area. So in terms of management, we can take skin swabs and send it for microscopy and culture and see if there are any sensitivities associated with it, and also a nasal swab. In terms of management, we can, of course, use the skin swab to direct our treatment. We can use oral steroids. We can use medications for the infection, such as antibiotics, and also give advice about shaving technique and see if there is improvement of symptoms if they're not shaving. Topical steroids would be avoided if there is an active infection. Tetracyclines can be used for their anti-inflammatory properties, and also isotretinoin. Phototherapy can be used in chronic cases and in non-infective folliculitis. So again, this is a presentation that is more probably common seen in general practice. And we would start off with the topical treatment and the skin swabs, and then go from there in terms of management. So now we'll move on to our questions. So we have a few SBA type questions to go through. So the first question is, a 32-year-old man who works as a builder presents with dry, fissured and erythematous hands. Given the likely diagnosis, what investigation will be best to help confirm the diagnosis? A. Skin prick test. B. Radioallergen absorbent test. C. Patch test. D. Skin biopsy. E. Skin scraping. See if you can put in whatever option you think is correct in the chat box, and then we can go through the answer. Okay, so I hope you've had a chance to think about the answer for this question. So
Someone said A as the answer.
okay. So in this case, it's indicating towards contact dermatitis. So it's giving some occupational clues relating to dry, fissured, and erythematous hands. Of course, in clinic, we can treat them with the appropriate creams and avoid direct contact and use of gloves or protective equipment for the builder. So the correct answer for this question is patch testing, C. So for contact dermatitis, like we discussed, we would need to do a patch test to determine if there is a hypersensitivity type 4 reaction present. And the other options can definitely test for skin reactions. But in terms of the presentation that this patient is coming in with the occupational risk factors, patch testing would be the appropriate answer. So our next question is, a 64-year-old man presents with a 9-month history of well-demarcated erythematous plaques with silvery scale on extensor surfaces of elbows, knees. He notices that it is worse in summer. What finding is most consistent with the skin trauma?
Two people have said B.
Yes, that's correct. So Koebner phenomenon. So the question is indicating to a diagnosis of a psoriasis, and as we discussed, that at the site of trauma, such as scratches and surgical scars, there can be development of psoriatic type lesions, which we would describe as Koebner phenomenon. So our next question is, a 16-year-old girl presents to GP with 4-month history of 2 to 3 closed comedones, 2 to 3 papules, and 2 to 3 pustules. She has not used any prescribed medications for this before. Which of the following treatment is most appropriate?
Two people have said D.
Yeah, great, that's correct. So all of these options can be used for the treatment of acne, but given the severity, it's the first time this patient is presenting to GP, topical benzoyl peroxide and adapalene would be the most appropriate, given there's only a few comedones, papules, and pustules present. So when there is a description of mild acne with a few inflammatory lesions, we would give a 12-week course of a topical cream. So like I discussed previously, there are various things that we can use. So topical antibiotic, topical benzoyl peroxide, topical retinoid. So these are just a few of the examples of the combination of the cream that's available. And you could, in theory, prescribe any of them. And our next question is, an 18-month-old child is seen in GP. He's got a history of atopic dermatitis. He's irritable at present and has a new rash on his face. He also has a fever of 38.1 degrees and is not eating or drinking well. Given the most likely diagnosis, what is the most appropriate management?
We have 2 answers for C.
Yeah, great. That's the correct answer. So we did touch on this previously. So in this case, we want urgent admission for the patient and give IV acyclovir urgently as well. So this is indicating towards a diagnosis of eczema hepaticum, which is a dermatological emergency. So the patient may present through peds ED, but as soon as we think this is the diagnosis, it's important we start them on the IV acyclovir. This is caused by the herpes simplex virus. And as you can see, there are clusters of itchy and painful looking blisters. And given that he's also not been eating and drinking very well, he may also need fluid assessment, may need IV fluids as well, depending on his hydration status. But yeah, the correct answer is C, admission in IV acyclovir. So that's the end of the questions. I will put the feedback form into the chat box. And thank you for attending. If you have any questions, then you can put it into the chat. But I can't see the chat box, so Anisah, if you can tell me if there's any questions, please.
No questions so far, just a couple of thank yous.
Great. Thank you for coming.